I'll start with you, Dilip. And I think the piece that I wanted to be able to hear from you on is really, how you think, private Indian healthcare groups are addressing the issue of both doctor as well as other employees' cost rationalization. And more importantly, I think, what we wanted to be able to learn and hear from you is how do you make some of these harsh changes more acceptable? How do you drive change? How do you actually, ensure greater buy-in as you work through these, very difficult changes at a time like this?
Yeah. I would deal with that question with a couple of contextual points, Kaustav. One is that getting through this pandemic with least damage is certainly the top priority. So whatever cost efficiencies that we are trying to implement, whatever cost efficiencies that we are trying to drive, should not impede our ability to get back to a growth path in the future. The second context that I would want to bring in is that whatever we do also should fit in with the ethos and culture of the organization. And just a month's data or a short-term impact, maybe 2 or 3 quarters impact that we see of the pandemic, we should be careful whether we impact the fabric of that ethos. We started with a pay cut for the management team, Kaustav, that, I started with me. I took a 25% pay cut for Q1. And then my management team, about senior team of about 50 odd people, we took a graded pay cut starting from 15% of CTC to about 25% of the CTC at the highest level. So more than the savings that it would drive, what we did was to demonstrate an intent that we can't go to our business associates or banks or doctors without demonstrating that resolve ourselves that, I have taken a cut, my senior team has taken a cut, and therefore I am approaching other colleagues and business associates with a proposal. So that's the first thing that we did. And what we also did that all the 50 odd people who are impacted by this pay cut at the management level, I made sure that I speak to them individually and explain, what made us take this rather harsh decision. So we impacted a similar graded cut that mirrored the management team, that 15%, 20%, and 25%, which is seen as fair and transparent. And what we did was, to all the doctors who were impacted by this minimum guarantee cut, we ensured that there was an individual conversation. And the second thing that we did, Kaustav, was that to be equitable, we offered an advance actually to the fee-for-service doctors. And while many did not opt for it, many did not want that advance, but they appreciated that gesture. They said, we did not expect it, and this is something we are happy hearing from the management. On the other side, Kaustav, the front-end workers, which is our nurses, technicians, we did not impact a cut, because the reason is that, they are the ones who actually deal with the patients in this kind of a scenario. Salary levels are relatively lower. If it were to make an economic impact in terms of a better cash flow, the cut should have been there because that is the bulk of the payroll is. But we decided that at the front line, we would not impact any cut. Finally, Kaustav, all the hospitals got a significant number of outsourced employees, housekeeping, security, those temporary staff that we have. There also we took a conscious call that we would not deduct or we would not ask for any reduction in headcount or a pay cut for a reason that many of them are at a minimum wage or marginally above minimum wage kind of a level. And if somebody gets laid off or, if there's a pay cut happens, pretty soon it is no food on the table. This was the overall philosophy how we approach this payroll and salary reduction.
Dr. Abhinay, if I move on to you and specifically have you talk about how you address the issue of employees cost beyond doctors, when you looked at outsourced labor as well as contractual labor, nurses, technicians, what was your approach, and did that approach really need to get nuanced given the different levels of stringency or rules in different states like an AP or a Telangana in which you had your operations?
I think our experience has been very similar to what Dilip is seeing. So, when it came to doctors, I thought it was very important for us to keep their morale up, especially at this point of the pandemic. Our fundamental view is most of the volume will definitely come back by the mid of Q2, the financial year. And we will see an annual volume, which is very similar to what we had seen in the last financial year. So then what we cautiously did to the doctors is we will not do a pay cut at this point in time, but we'll manage our cash efficiently. So we'll make part of the payment in the month of April and the month of May, and the rest of the payment over the next half of the year, subject to the volumes coming back. So as far as nurses and healthcare assistants are concerned, I agree with Dilip. The compensation levels are very low, and 70 to 80% of our workforce are essentially them. So I think trying to optimize cost at that level is going to become very, very difficult to ramp up when post the lockdown. So we had also taken a very cautious call that we will not do any pay cuts there. We will ensure that there's no layoff happening in that category of employees. However, we put the hospital on a very lean rota, and we had asked a few people to take voluntary leaves for a couple of days, especially when the occupancy of the hospitals have been significantly low. And what also happened with us was 3 of our hospitals were designated COVID hospitals, and this kind of created a lot of scare among among the employees, and close to 30 to 40% of the workforce actually didn't report to work for a couple of days. So we had to actually sit down with each healthcare worker, nurses, housekeeping, class 4 employees to actually talk to them about what COVID is, because their understanding about this whole thing is very low. So we had to spend a lot of time not just counseling them about financial, but also the other aspects.
I'll quickly switch over to Larry, and Larry, it would be good to have your perspectives on what kind of cost rationalization measures are US private healthcare groups considering? Do you see a situation very similar to India, or have there been initiatives which are slightly different, given the fact that you do have some degree of federal government support at a time like this?
What's going on in this country is a little bit different in that the federal government, in fact, has come up with a significant amount of money. The first tranche of money was $175 billion directly to hospitals. And it was paid basically with a formula initially based on the number of Medicare patients that hospitals were seeing, but subsequently it was based directly on the number of COVID-19 patients that were seen. So most of the hospitals, interestingly, that received the money were in New York, which is where sort of the epicenter of the pandemic was in this country. And the House of Representatives has just passed another $3 trillion fund, which likely will not be approved by the Senate, I might add, but there'll be some negotiation. So for one, we've seen the federal government step in and send money directly to hospitals. The other is we also have seen furloughs almost across the board. So I know for a fact 253 hospitals that we know of are reporting furloughing workers, some as much as almost 20% of their workforce. And this, interestingly, is not physicians. It really is those frontline workers, because if you look at volume across all service lines, what we've seen is volume down by more than 50% across all service lines on average. So some we've seen significantly higher than that. So that has meant that we've been able to furlough in many of these hospitals a significant portion of the workforce. So in full-time furloughs, others have been sort of part-time furloughs where people have taken less hours. But that clearly is one of the things that has been front and center, is that places are furloughing workers. And as I mentioned, it could be up to more than 20 or 30% of the workforce, depending upon the hospital. The other thing is that Medicare pays money up front to cover the perceived volume would come back. That money needs to be paid back, but many of those hospitals did take that Medicare money up front. I think the other has been most places are deferring a lot of their capital expenditures that they were planning on. Many of them have, and as has been mentioned, Most places have taken pay cuts among the administrative staff. So among the leadership, pay cuts have been taken. We have seen pay cuts among physicians as well in a number of institutions, usually on a temporary basis for 2 or 3 months, and then there'll be a re-examination.
Thanks a lot, Larry. Obviously, the situation is quite different as we understand in the United States with the extent of federal government support that you're getting. But there are learning for dedicated COVID hospitals. I mean, I'm just relating back to Dr. Abhinay's point that 3 out of his network of hospitals are dedicated COVID hospitals, and clearly, if one were to get support from the government in terms of something equivalent to a furlough, where the government can come in and share costs for operating these hospitals or share costs for some of these resources, even that would be a significant relief for some of these hospitals amongst private healthcare operators who which have been designated as dedicated COVID hospitals. Dr. Abhinay, would you agree on that aspect?
Totally agree, Kaustubh. So we actually put down a representation to the government, given that so just take a example. One of the district, we have 1,000-bedded medical college. The district has 3 COVID positive patients. The entire hospital is designated to be COVID hospital, and the entire hospital had to be evacuated. So essentially, for 3 positive patients for the district, you're locking down a 1,000-bedded hospital. So there's a lot of cost associated with it. So we'll have to do something about it. So we made a representation to the government. So we're hopeful that something will come through.
Yeah, and Costa, if I could just add, we've not had designated COVID-19 hospitals. Essentially, every hospital has taken COVID-19 patients.
I could quickly come in for a second. We have a hospital in Kuala Lumpur, and the Malaysian government has given a subsidy for salary up to 25% for 200 employees. So that is something. You are making a point a few minutes ago, Kaustubh. If the government were to chip in, what could happen? The Malaysian government has actually gone ahead and done that.
If I, take that cue from Dilip and move over to the experience in Southeast Asia, more specifically Indonesia, Varun, as I obviously talked to you, I did realize that Siloam is a bit of a case study. If you could just, quickly summarize for us, some of the 2-3 key pointers or learning that we have from your experience of Siloam operating through this period of crisis.
So I think the first big piece that we needed to answer was, do we get into conservation mode or do we go aggressive? And I think we chose aggressive. 2 reasons for that. One, the lack of infrastructure in Indonesia on health. And the second, I think the ability of the public health system to be able to handle the pandemic. When we started to build our strategy, we said we're going to have 3 pieces, 3 big pieces. One, how do we bring back the base business, right? The second, how do we make this opportunity of COVID come alive for us? No one's ready. We'll be ahead of the game, well out of the curve. The government is not ready. Will we take COVID patients? How do we get up for that? How do we develop testing both on PCR and rapid across our network of hospitals? We are large. We are, like India, we are the only private operator in this country which has presence across Indonesia. And the third part was, I think, which was a significant part and probably has added to the EBITDA the most in the last 2 months, was how do we make the best of this opportunity? People are going to be struggling by virtue of the impact to hospitals, to healthcare. There'll be a lot of learning that we'll be able to share. On the base business, I think we realized that there are 2 issues. The first issue is demand. Really, demand evaporates. People don't want to come to a hospital because they're scared of COVID. And the other thing which went in parallel, and some of you have already alluded to it, is supply. Supply also vanished. And what is supply in our business? Supply is the availability of clinical talent to be able to extend the services. The first thing that we did was we decided to keep COVID and clean hospitals. So there were certain hospitals in Jakarta. We run about 8 hospitals in Jakarta. In Jakarta, we were to open 2 hospitals over the next 10 months. The structures were ready. So we decided, in the large hospitals, cumulative capacity of both these hospitals is about 600 beds. So we decided to go aggressive. Now, Interestingly, the strategy seems to be working. Early days though. In many of these hospitals, we have an onco specialty hospital, we have a transplant hospital. Now, this is where we see a lot of immunocompromised patients. So when we started to tom-tom about the fact that these hospitals are COVID-free, they were willing to walk in. And when that happened, our doctors were willing to come back. So a hospital that probably had 20% attendance on account of clinicians is today seeing about 60-70% clinicians operating on a regular basis. So I think that's one piece that really worked in our favor. The second part of the strategy was really the COVID business. We were again ahead of the curve. There was limited testing capacity in Indonesia, including the public setup. So we got started with the PCR. When the PCR got started, we also started to see positive cases, and they needed to come and get admitted. So we created a COVID class tariff, which is a separate tariff completely. We couldn't do COVID hospitals really across Indonesia. So we picked up 10 more hospitals where we thought we could do wings. So we created COVID wings. And as we speak today, we are operating about 1,000 dedicated COVID beds in the country. So that's, I think, a significant part. The third thing really I want to talk about is the innovation side of it, or the new things. Needless to say, the first one in that was digital access. What we really did, we adopted a low-tech and high-intervention solution, which was, we've started advertising it, now we call it Siloam at Home. So we really took the same specialist that a chronic patient has been seeing for years to be able to consult with the doctor, with the patient, when the patient is at home. And to complete the continuum of care, we started home care services to a limited extent. So pharmacy delivery started, we started phlebotomists going home, and so on and so forth. So I think that again allowed us to, one, differentiate our service. We got closer to the patient. The patient got the same specialist that he wanted. And we have a centralized call center here where you can access an appointment or any doctor in any part of our country. On the innovative side, and that's probably the last part of our, last and the most crucial part of our bottom line and the revenues too, is the consulting services. So Indonesia really has a lot of expats living here. There are a lot of multinational companies like India operating out of Indonesia. And because the health systems are weak, extremely weak rather, the fear element was also significantly higher. They all needed consulting assurance. And I think we played that big part on a joint basis. We consulted with them. We developed assurance products. And that was immense revenue as far as we're concerned.
So I'll take that final point and move over to Dr. Raghuvanshi. Dr. Raghuvanshi, in terms of using digital OPD or telehealth as a mechanism, what has been your experience or what you're hearing from other healthcare groups in India?
Yeah, I think it's the landscape is similar in the sense that there are a lot of, as you all know, a lot of startups who have been in this space for quite some time. So now telemedicine has been something which has been talked about a lot for last 2 decades or so. However, there has not been a serious effort, and I think their adoption has been very poor, both by the clinicians as well as the patients. And this particular epidemic has brought this into focus. And as a result of that, I think the acceptability of this platform has gone up. Now, most of us, I think, weren't prepared with a ready-made product which we could, shift to a platform. And I think there is a challenge which has to be kept in mind, that the traditional providers would end up probably losing a market share of OP consults to these new players who are technology-based platforms. So I think it is important that hospitals do consider that this space is something which they cannot avoid. The new paradigm is going to be different. And I think post-COVID also, these things are there to stay. such as in case of our organization, we also used similar things as Varun said. We just used Teams and we created a payment gateway, and it worked out quite all right, I would say. So much so that almost pre-COVID OPD attendance, what we used to have, we are able to address almost 10% of that amongst our hospitals. And mind you that not all clinicians have gone onto that platform. But one of the things which we have to remember as a provider is that that's just a one-off transaction. To be important in future is if the entire continuum of care is can be provided, and that's where I think various elements and interoperability etc will become very, very core to how this will progress. And I want to point out one thing. There were certain structural problems in the way the leads are generated and the way the business patient funnel functions in this country. And I think it is important for us to realize that in many ways wasn't sustainable. So just put that into a digital platform is not necessarily the way forward. What is important is probably new ways will emerge. And I think some of the aggregators and all, I think they will become important components of patient funnel per se. And one of the most important thing is going to be that the consumer behavior is also going to change significantly as to how they access healthcare. You see, within India, other than what Varun mentioned, that 10% patients coming from international patients, but within India, there is a lot of movement which happens across states. And I think going forward, there are going to be restrictions on the way people travel. I think the restrictions could be self-imposed or because of fear or because of actual restrictions. And those will make a difference into where the patient flow happens.
That's very helpful. If I just switch over to Viren here, Viren, one of the things I wanted to pick your brains on is the importance of analytics in terms of figuring out who to reach out to and what frequency I reach out with what kind of a service, what kind of a proposition.
On the analytics, it's gone in very short span of time from buzzword into something that's almost mission critical. There is this old saying, if you cannot measure something, it probably doesn't exist. And the fact is that if we're looking at cost cutting across every part of the organization, if you're looking at the effectiveness of a marketing campaign, if you're looking at which areas you want to focus an effort and outreach on, if you don't know for sure with hard to arrive at interpolations, if you don't know on a deep granular level, it's simply impossible for you to be able to plan anything sensibly around that. So one of the initiatives that Dr. Raghuvanshi, when he was with us, pioneered was this large team that went about moving from Excel files to something that approached a modern business intelligence organization. And so what that involved is, one, being very clear about the levels of data presentation that we need, and moving from that onto how we can move from just analytics into prediction. And so we're at the level now where we're able to take the vast amounts of data that we have and use that to actually predict which areas we should start focusing on. And so we started mining our data to try and figure out where are the non-traditional places for us to attract patients. Now, one example is I'm based in Bangalore, and this is where our main health city is. And we always assume that patients come to us from East India. But upon looking at the data, we actually find that Central India was this place that was quite overlooked. And so we started targeting places like Aurangabad in Maharashtra, Indore, Bhopal, Lucknow, who we normally think these are patients that go towards Delhi, they go towards Bombay, but the fact is we weren't reaching out to them. Now that we've also gotten onto the telemedicine bandwagon, it is a lot easier for us to provide that first consultation to them at a very attractive price. And once they speak with our doctors, they get a much better sense of hospitals that they can approach that they wouldn't normally have gone to. What happened is that most people ended up going to hospitals blind in the past. Their first experience with a doctor was when they walked into his office. And I think what this pandemic is forcing us to do is to start removing those barriers, because now coming to a hospital is simply not an option. In telemedicine, yes, I mean, that is just one of them, but there are many other tools that hospitals should get into. And that is around patient outreach, digital marketing. We do a lot of seminars with doctors talking about COVID and preparation. We've moved our entire appointment and booking systems online, and we're even working towards digital follow-ups. So yes, hospitals will definitely need to start looking at that, which takes me to the second point you brought up, which is e-pharmacies. There is a role when hospitals want to finish up the continuum of care. It's one thing to do the consultation online, but if you want to actually be able to deliver pharmaceuticals or any sort of bandages and so on, you need someone else to close the loop. It doesn't make sense for us to try and do everything ourselves. And in that instance, tying up with other partners who are much better at logistics than we are would make a lot of sense.
Thanks, Viren. Dr. Raghuvanshi, you did make a point earlier. I'm just switching over to that aspect of that whole B2B outreach, which obviously you did mention traditionally has always been very transactional, and some of that structure needs to change. Now, one of the things I wanted to also check with you is what are your thoughts in terms of how you continue to engage with the entire referral doctor network at a time like this, because there are some very interesting case studies or learning that are coming out of pharmaceutical companies, the more mature formulation companies in India, who are being able to use very, very cutting edge e-detailing tools.
Yeah, I think it will evolve further, and it is going to be a much more viable way of doing it. Just imagine a sales rep going to two doctors in a day versus sitting at one place and connecting with 100. So I think this is going to be adopted in a big way. And as you said, I think what is going to be more important, and as Viren was saying, that analytics of how exactly the business flows from those areas and what are the needs and demands of that market. I think that plugging that into the whole equation is going to make it more effective. So certainly, I believe that these tools are going to become the mainstay, and that is going to also decrease the costs in a significant manner. Information will be more powerful, it will be more effective, the interactions will be more sort of nuanced, and at the same time, the costs are going to be relatively lower.
I'll move over to Viren once again, okay, and ask him. There are obviously, these ideas related to the whole B2C and B2B marketing model evolution, but separately, post-COVID, what are the new paradigms which will actually lead to a more efficient, cost-effective organization?
Yeah, driven by the sort of initiatives that a lot of the other hospitals have taken up. One of the biggest things that we find with a large group is that we really want to start utilizing our efficiencies. And so we've divided our organization into different zones. We have a zone in Karnataka, in the north, in east, in west. But what we found is that there's just an element of replication. This is the time that we have to take an axe to that these positions. So what we started working on is, one, a centralization of services that are not patient-facing. And so what that means is anything that is more in the back office, which is work that more or less resembles what a robot is capable of doing. We centralized it and started moving people into common pools. And then we're going to start to realize that a job which has a total of 16 people doing it can probably be managed best with 10. And the rest of them can be redeployed towards areas which are opening up. So shared services is a great opportunity for hospitals to really streamline a lot of their processes. Patients, one of the panelists earlier was right, our volumes may never recover to the way they were earlier, but what instead will happen is the nature of our business may change. It may be that hospitals don't be this one central place where everyone congregates, but you operate in a more distributed manner. If that is the case, then we need multiple locations, in which case you have people who were sitting in the back office probably be more patient-facing. There are people who may be stuck behind a computer all day. They'll be on call centers. They'll be doing a lot more outreach. Marketing won't involve driving or flying around anywhere. It will involve a lot more digital tools. So the nature of the work is changing, and we obviously have to change along with it.
I'm just wondering, I mean, is it only the culture and that, inertia which we had as hospital groups in India, did not allow us to move down that path, or are there other enablers that you need in place before you can, bring in, interventions like RPA for hospital groups in India?
A financial crisis always helps. These things would have happened. It would have taken a lot longer because healthcare is a notoriously conservative business. And it's one where you want to make, it's about mistake minimization. It's not so much about making bold and fancy strategic moves. A lot of this business is just taking one innovation after another. What this has done, it has accelerated that. So everything you've spoken about in robotic process automation or in the implementation of AI for a lot of back office functions will operate on a much more accelerated path. But I would still say we are maybe 2 steps behind when it comes to other industries in their adoption of digitization, because most of our processes at this point still depend on paper and manual overrides. So we have to solve for that first, which is a challenge for most organizations, including ours. As much as we have a very good tech stack, the fact is today, most of our doctors still use paper. And most of the billing processes have manual systems in there. And most insurance companies, their systems don't talk to ours.
I'll move back to Dilip. And this relates to the area of health risk management for your workers, right?
I would certainly think so, Kaustav. A couple of things on that. One is currently when the pandemic is at its peak, the safety of employees, safety of all our clinical teams and the patients is top of the mind for everybody. Therefore, automation is something that we would need to look at, whether it is wearables where, it is tracking the social distancing, it is tracking exposure. I think that's an opportunity that, would come about certainly. Second thing we need to keep in mind is the social distancing would certainly bring down the capacities of hospitals as it exists today. Not only at the outpatient, conversation level, but at the labs, at the radiology. I think that would bring down the capacity in some form. So therefore, optimizing that along with maintaining the safety is something that technology would have to support the hospitals with.
Thanks a lot, Dilip. Larry, if I may go back to you just for a minute and have you contrast what you have heard from Dilip and from Viren.
Yeah, I think that it has been mentioned. We certainly have seen a consolidation of back office functions to be more centralized, especially among the larger health systems. Much of that has been centralized. I think we've seen a significant increase in artificial intelligence use in some of these back office functions. Clearly, there are things that don't need to be done by a human being and can be done with machine learning and can be done using artificial intelligence. So I think we've really seen a significant impact.
So let me then move over to that area of how supply chain for hospitals are likely to evolve. And I'll request Anish to come in over here. Question to you, Anish, is really around the fact that do you see distribution into hospitals changing? There are new alternatives that are coming up by way of larger distributors or more consolidated distributors, as well as B2B platforms, okay, enabling your supply into hospitals. So what is your medium-term to long-term view of how your distribution into hospitals could potentially evolve?
Thanks, Kaustav. So, again, when norms change, one ends up finding newer and innovative solutions. And I guess the current situation will give an impetus to all the companies to reevaluate their route to the market. And also, there will be some significant shifts, but they require a clear framework. Now, what we are seeing is that, one is, of course, there is going to be a consolidation amongst the channel partners. I guess there's a very long chain out here in India. And there has to be consolidation for them to manage the cash flows much better and weather the storm together. The other element is that of SKU rationalization, right? I mean, while there's some great SaaS tools that help you rationalize your SKUs better and manage your stocks better, but there's a fair degree of difficulty on SKU rationalization because of the involvement of multiple stakeholders and opposing views. And I guess that's where we'll see a much more alignment between the supplier and the purchase of the hospitals in terms of rationalizing the very large number of SKUs they carry, especially in the field of medical devices. And I think the third point, I would sort of bring a Southeast Asian example.
Thanks, Anish. Gurmeet, what's your expectation or perspective on how your distribution models of products to hospitals could evolve?
I think moving on to large distribution platform, I'll probably not indulge it unless it is a part of my business strategy, more in a long-term view. One of the major challenge today, what we have is our demand planning. We really don't know how much the hospitals will do work. So demand planning is really a challenge, and of course you just cannot consider outsourcing it to a large distributor that they do it for you. Secondly, in terms of transportation and logistics, that's the second challenge. So any shock in transport and logistics, it's whatever is it for us, will remain for a large distributor. And third, then the issue is also the financial resiliency of the company. How much are we ready? Today we are dealing with hospitals directly. So we have agreed payment terms from the hospitals. Tomorrow we will be dealing with these large distributors who ultimately will become like a buying agency for the hospitals. And then your same issues start with them. And also one must understand, as far as you are in commodity products, which is low end at the spectrum, you can still move on. But if you are in a range like ours, which is, if your product offering is complex, it needs service support, it needs your people to reach out to cath labs, to hospitals and surgeries to assist them, then surely you cannot use these platforms. And most important of all is your organizational maturity. It cannot be a very great idea to immediately move to these large distribution houses, because it will be just postponement of the problem. It won't solve the problem. I think rather than consolidation, penetration is the key.
Back to you, Anish, and ask you, what are those 3-4 key factors which has helped Healthium as an organization negotiate the crisis and work through this period? If you can just walk us through that case study.
Our focus was on a few things. One was procurement of raw material. A lot of raw material we use is imported. So what we did is we built inventories of raw material for 6 months, and also built finished good inventories for 3 months, because one didn't know when this and how it would play out. And now this was a deviation from our lean norm, but sort of a good decision in hindsight. And I guess that's where the nimbleness piece that Gurmeet spoke about becomes very important to organizations like us. The second was managing our cash. We knew cash was king, and building scenarios to make the money last as long as possible. And this was primarily by focusing on the collections, getting our limits enhanced with our bankers, and also making sure that we curtail all unnecessary expenses. The third was to make sure that our stocks don't sit in a warehouse. Right? We were one large warehouse, but what we did is we spread our stocks across 27 different locations, because we had no idea how the geographic spread would happen, if the disease did break out in India. And I guess, the one thing that we did is we did not look at supply chain costs at all. So, once the supply chain started improving, there were transporters that charge us 3x, 4x, 5x, and we continued with the supplies, because what we wanted to make sure is that, we were first in the market, and we were available wherever the hospitals or the nursing homes needed us. And sort of guess, lastly, the largest help was the essence of a diversified portfolio, because, while elective surgeries have been hit very badly, and, hit rock bottom, our urology portfolio in the UK and our consumables business actually got a great fillip, and we were able to do a balancing act with a sort of diversified portfolio.
Good. My question to you here is around the fact that obviously hospital sector is under some severe pressure. Do you now see this being an inflection point for Indian homemade medical technology companies? Do you see this will actually spawn an opportunity for hospital providers to consider medtech supplies from Indian companies such as yours or Anish's more seriously as they go ahead?
I think, Kaustav, that's $1 million question, and I think there cannot be a better time to implement it now. I think there needs to be a responsibility in part of the ecosystem where hospitals play a very vital role and supported by government, and there's also need to be a very high responsibility on part of the Indian medtech companies. So as long as the hospitals and the government is allowing the market access, the companies will really come forward to work on quality. The sloganism of being vocal about local or make in India would not see the light of the day unless this really comes in the whole ecosystem. Now, from a medtech company perspective operating in India, we need to be very clear, and we don't need to get too much patriotic about it. Nobody wants to get up substandard products, irrespective of whether it is manufactured in India or is it manufactured in China, Korea, or US. Everybody wants a good quality product. So Indian medtech companies need to work extra hard. You just don't need to create quality. You need to create very high quality, because an adverse event coming in American products will still be justified. But if an adverse event comes, in an Indian manufactured product, everybody will cry it, and people are writing about it and they are reporting it. When the products were being evaluated, we considered 2 American products as a comparator, and we couldn't take other Indian product, we couldn't take other European products, so it had to be American. And then when the evaluation, the timelines were created, most of the companies were closing their evaluation at 5 years. And when we discussed with our European clinicians, we said, can we do it much longer? And we ended up doing it, studying the product for 10 years, because we had to prove extra hard to the hospitals and the doctors here to consider us, that a lot of loss which they might have from operational reasons, they can easily be covered by engaging Indian companies in the partnership. And Indian companies probably might also be a much more resilient in terms of sharing the pain, which is right now going to come in the cash flows. Because we are in the same ecosystem. And if you are not getting reimbursement from CGHS or ECHS panels and everything, we influence those much better than anyone else. If you don't get paid, we invoke our Indian startup or MSME laws to ensure that hospitals get paid so that the companies get paid.
Going back to Dilip, my question is, obviously you've heard both Anish and Gurmeet, and there is this opportunity for Indian medical technology providers to offer products at a lower cost in a quality compliant manner, supported by international clinical data. And added to that, there is this whole Make in India movement or initiative, which is being spearheaded by the Indian government. Now, with that context, does it become easier for hospital groups to now convince their doctors to try out some of these made in India but high quality products? Do you think the time is here and now?
So I think the gate would be quality, and the price comes after that. And if the Indian medtech companies can consistently demonstrate that, I don't see a challenge at all. It will be most welcome.
The time is appropriate for the those quality compliant Indian companies and the hospitals to collaborate actively and redevelop the trust together. I'll move over to the final question of the evening as far as the panel members are concerned, before taking a couple of questions from the attendees. And this once again goes back to that point around government support and what healthcare providers could use by way of government support.
I would say one of the key stumbling blocks in this business has been the cost of capital and the low return on that capital. We had done a calculation, I think 4 or 5 years ago, where we figured out that every greenfield hospital returns less over a 10-year period than just the principal amount of the loan that you would take to build that hospital. So no one's lending you, at 0% for 10 years, but even if they did, no greenfield hospital in this country would be viable under conservative assumptions. Now, here and there, of course, you can have some outliers, but the fact is the economics of healthcare in this industry are completely skewed. So if we're in a position to ask the government to do anything, I mean, there are many other things that they could do, but to support, I would say one of the key things they could do is give us working capital or loans at 2, 3, 4% interest rate. I would say we have every intention of paying it back, but at the current interest rate, it's just not viable to keep our businesses growing.
So working capital support at low interest rates is essentially what you're leading to. In addition to the point that Dr. Abhinay had made earlier in terms of actually footing the bill for some of these hospitals which are now designated COVID hospitals. And clearly we see more of that happening. I mean, especially in hotspots like Mumbai, where more and more private hospitals are going to be either designated as COVID hospitals or would have to reserve a larger part of their bed capacity for treating COVID patients. Fair enough. So thank you everybody for this very enlightening panel discussion today. I mean, just to summarize from our perspective, from my perspective, one of the key takeaways was really around the fact that there are clearly new models, paradigms for both consumer engagement as well as doctor engagement that are on the anvil, that are likely to emerge post-COVID as we come out of lockdown, as we negotiate, through this period of the next 8, 10, 12 months. And that, for me personally, is probably one of the most exciting areas of evolution to look forward to, because this will mean new ways of doing business, as Dr. Raghuvanshi was saying. Some of the structural changes actually potentially could play out in terms of how we do our transactions, how we basically engage with our B2B referral doctor network. So that's one clear evolution to look forward to, and that is definitely a big learning area. The second piece that was also very fascinating to learn about was obviously the fact that US healthcare groups have all moved down that path of driving cost efficiency, especially in a payer-driven kind of an environment. That's been the norm for US healthcare groups. They have used bots, robotic process automation, and other IT intervention measures, shared services model at the back end for them to be able to optimize on their delivery costs, figure out what is outsourceable, what is not, and then bring down their cost of delivery. And very clearly they talk about the fact that it might take a little bit of time. Those could definitely also play out in the Indian context. So that's the second big area. The third thing that I learned was the humanitarian approach, or the humane approach of driving cost changes in hospital groups, because you want to do the right thing for the doctors, for the nurses, for the technicians, and the patients. So stand by them at this time. I mean, especially your low pay employees and workers. Do not necessarily cut the corners there. And when it comes to doctors, do this in a way where change is more acceptable, and it is in keeping with the ethos and the culture of the organization. I mean, essentially driven by more fair, transparent, and equitable communication on a one-on-one basis with these doctors who are going to be undergoing changes. And finally, moving over to the supply chain element, I think pretty much all of us here agreed that make in India or not, or being an Indian company or not, is not necessarily the criteria that is being used by hospital groups for evaluation of products anymore. And Dilip did mention that hospital groups have been open to Indian-made products as long as they're compliant with the quality norms. And Gurmeet also talked about the need for quality as well as transparency in kind of building this partnership model with hospitals. So hopefully we'll not see an inflection point there, but definitely we can look forward to more Indian-made products. Okay, the more cutting-edge companies within that Indian-made category finding penetration in some of their large groups. So that for me is essentially a very quick summary. I'll just take a couple of questions and see if there are any additional ones here before we wrap up our today's session. So one question that we have for the panel from Srinath Reddy. Dr. Reddy is really asking that telemedicine could be a money loser for hospitals. So he's essentially saying that patients will get their diagnostics done at home, buying medicines from the local pharmacy, and your overall patient income is actually going to go down, right? So as you supplant your regular ways of engagement with patients, which is your regular in-hospital outpatient and diagnostics, and also inpatient admission, some of that getting supplanted with telemedicine, how does that impact your overall economics and profitability? Anybody could kind of take the lead and respond to that question. I think between Dilip, Dr. Raghuvanshi, Viren, Dr. Abhinay, whoever wants to take that question first.
So if I may quickly go, I would attempt to say that a point that I made earlier, that effective capacities of the hospitals are going to come down. That if we are doing, like I said, 2,000, 2,500 OPD consults a day in the past, we would not be able to do the same going forward, given the social distancing. there is an opportunity. You might want to triage your consultation, OP consultations, into what can ideally move to teleconsultation. Certainly follow-ups. The other way, the data mining that Dr. Raghuvanshi talked about earlier, you could look at which departments, your per patient in revenues. If you look at ARPP at the OP level, is different for different specialities. So you might want to triage certain specialities which you would only do on telemedicine, and prioritize the physical capacity in the hospital for higher ARPP consults. So given that capacities may be constrained going forward, I don't think there is an option of not doing telemedicine. The option could be to use it for a triage purpose, and then follow-ups and move low ARPP work into telemedicine.
Got it. Got it. Anybody else on the panel wants to add on to that perspective from Dilip?
Am I audible?
Let me try and take it. Can you hear me?
Yes, please.
Yeah. So, Kaustav, I think it's a great question. When we first started this, we realized that potentially there could be loss of revenue on account of testing and files really going to the others. When you look at the overall picture, which is what I mentioned, that you go to club a video consult or a consult that you're doing, or a teleconsult for that matter, with the other services as well. So it has to be an integrated solution. And that's what we try and drive with the technology intervention that we have. So we do the consult, we use our medical record system, our integrated HRSs, and then try and deliver to the patient the pharmacies. So we're able to do that. And also send phlebotomists. So there is a home care services network that has been established. There are ways and means that you can use technology today to be able to deliver the entire service, the entire bouquet of services at home.
Sure. Okay. An add-on question that we have from an attendee, Kirtiman, is asking us, what are hospital groups likely to do, or what is it that they must do to make patients more comfortable for them to be able to adapt to this new normal of telemedicine or digital consultations?
Yeah, I can answer this one.
Sure, Viren.
Yeah. We have to treat it like a continuum. As what Professor Srinath Reddy said earlier, which is, if you think of telemedicine just as I'm going to the doctor to talk about my aches and pains, that's a very self-limiting way to think about the potential for a digitized outpatient department. Now, the entire experience of going to a hospital is miserable right now, because there are multiple checkpoints. We're screening them. We're doing outdoor fever clinics. They go through multiple rounds before you finally end up with the doctor. So what we're working on is streamlining the entire process, where all the history, every checkup, all the consultation is done before you enter the hospital. So that from the time you enter till when you see the doctor has to be an experience where you don't make contact with a single person. And so that is one of the chief ways where the entire patient experience can be improved. When patients come for the inpatient work, for surgeries and procedures, that's fine. I mean, by then, that is in most hospitals, that is only 1 out of 10 to 1 out of 20 people will be coming for inpatient. Most of the work that we do is on the outpatient side. So I would say we have to invest a lot in streamlining the entire process so that they spend as little time with front office, with billing and all of that, because all of that can be done online.
Sure. Thank you. Thanks, Viren. There is a question from CDC, Abir Seth from CDC. I think Abir's question is really around the fact that so far a lot of the treatment and testing for COVID patients in India has focused on public hospitals or those designated COVID hospitals in the public sector. So Abir's question is really around the fact, what are private hospitals doing to ensure that they are fully ready? They are enhanced on their readiness for them to be able to take on the spillover load if the pandemic really reaches larger proportions in India.
Yeah, I'll take a go on that. Private hospitals have not created the infrastructure simply because they weren't allowed. I don't think it is very complicated to create the infrastructure. In our diagnostic business, we have got multiple labs which have got RT-PCR and which is recognized by the ICMR. However, if for the private hospitals to step up, that is not going to be very technically challenging. The only part is getting the proper molecular scientists and doctors for doing that. Otherwise, as far as infrastructure is concerned, it is not very complicated. And I'll share with you, in a very remote place called Devgar, there was an issue because there wasn't enough diagnostic available, and we were able to put all things together. Though it is not functional as of now, but it will another couple of weeks it will be ready, and the entire process took us just about 4 weeks time. So it is not very complicated to put the infrastructure for private hospitals, especially in the corporate sector. Many hospitals had labs which could do the testing, but weren't allowed. So I think it is more of how the testing protocols are being governed by the administration. So I would say that the creating infrastructure would be the easy part.
Sure. Thanks, Dr. Raghuvanshi. I'll take one final question because we are really, coming to the end of our session. I think so. We have a lot of other questions also coming through from the attendees, but I'll take one final one, and this has come from Punita. So Punita is asking, how will medtech companies interact with doctors now that there is a social distancing norm in place, limited access? Is there an innovation that is required in communication? Okay, and what should that really be at a time like this, where there's limited access to doctors and to hospitals?
So, Kaustav, I can just give you a little bit answer on this. Because last 4 weeks and 4 to 6 weeks have been extremely revealing. Because when the shock of COVID came, the first part was that we couldn't just go to the hospitals, and especially when you're selling high-tech products, which requires a lot of in-service to the hospitals. The challenge is, if you don't reach, how would you talk about technology? How would you give them the updates? But I can tell you, one of the most revealing, it's similar to what people realized about digital payments when demonetization happened. I think a similar revelations which has come for companies is the power of digital connect. I mean, I think we have conducted more than 14 webinars in a space of maybe 30 days. The good part is they're cost effective, they are more customized, they are more personalized. You have your target audience, and you create interest. You see the interest of the target audience and keep it. But one of the challenges, I think, which each medtech company needs to be very careful as they move forward, is that whether that your doctors and your customers will give you once or twice an opportunity, and if you didn't add any value to it, they will never get connected to you again. So this is the other side of a digital connect. And so you need to be authentic, you need to have a technology, and you need to do something that creates extraordinary value for them. So which also means that the way you are planning it creates something where they actually learn. And interestingly, I can tell you that we are embarking this weekend on an e-conference, because our the major conference which happened once in a year in Europe called PCR for cardiologists, it got cancelled. So there were a lot of cardiologists who had cases with them and their lectures were ready. So it took us 12 days to organize an e-congress of 200 cardiologists across India, and also I think around 25 of them from international, on a digital platform, and where they'll be exchanging cases with each other and they'll be talking. So that's the power which the companies have realized now. And I think moving forward, irrespective of the the physical movement being eased, digital connect between hospitals and medtech companies or pharma companies are here to stay for a very, very long time, as long as company takes it in a more innovative and responsible way.
Sure. Thanks for that response. We are really now about exactly half an hour over versus the overall time that we had scheduled for this discussion. I can't tell you, how indebted I'm to all of you, my panel members, for taking time out from your busy schedule and making it to this session today. I can tell you this, at least for us here from Alvarez and Marcel, it was a very, very value-adding, enlightening kind of a session. And I'm sure it was pretty much the same for all of the attendees, both from private equity groups as well as from other healthcare groups in India who joined us today on this discussion. So thank you all once again. My heartfelt thanks to all of the panel members for staying on with us for the last couple of hours and sharing your insights and your perspectives. And thanks to all of the attendees also for staying with us through the course of this session and listening to us patiently, also asking us specific questions on what could make or break this sector. On a personal note, it's really a little sad that a discussion like this had to happen digitally. Maybe it's a pointer for the future. But I do hope that we'll come out of this strong. I mean, individually, all of us personally, as well as collectively with all of our organizations. And I do look forward to once again being in front of you face to face and carrying forward our discussions on the other side of this crisis. Till then, wishes for good health and safety to all of you. And thank you so much once again for joining us.
Alvarez and Marcel. Leadership, action, results.